Namaskar. We would like to welcome you all on behalf of Independent Research Ethics Society, AYUSH Samriddhi International Webinar Series at milestone of 2372. Thank you. Thank you very much for your overwhelming support, mentorship, and guidance, due to which, by inspiration and coordination of Professor Kamini Dhiman, we are continuing two series: Thursday Infertility series, Saturday Women Wellness series. So thank you, Kamini ji. Thank you very much. Thanks and welcome to Professor N. Vijay Kumar, Professor and HOD, MS, retired, Department of PTSR, Government Ayurvedic College Hospital for Women and Children, Trivandrum. Welcome Vijay ji, and all experts of the dais also, because of the dais also all experts are here. So thank you, Madam Veena Roji. Thank you very much. You are a guide in PTSR. So thank you. Aji, Swati ji, all are welcome. Before wasting much time, I would like to request Kamini Dhimanji for her initial words as well as coordination. Welcome, respected Kamini.
जी नमस्कार पवन जी वेलकम डॉक्टर कुमार to platform of Ayush Samriddhi. As Pawan sir has told that we are doing webinars every Thursday on the topic of infertility. And Dr. Vijay Kumar is very well known, we can say that academician, very well known clinician in the field of male and female infertility. So this was a very good chance to have him to this platform on Thursday for the topic of infertility. And as you all people know that endometriosis is very much common nowadays, and we are having patients of endometriosis in our OPDs, sometimes having complaint of dysmenorrhea, but lot many patients who are having infertility are having associated issues of endometriosis. Although patients are coming to us with the diagnosis, or we can say that the complaint, we are giving them our Ayurvedic management or Ayurvedic treatment. We are giving them the relief from this, we can say, the burdensome problem. So today we will have Vijay Kumar sir on this topic. He will discuss, and I would like to welcome Beena Rose madam also, Nishan Shukla ji also, Suresh sir also, and welcome all the dignitaries join over here. After the presentation of Vijay Kumar sir, we will have discussion and view of all the experts also, whosoever want to add their views, or the participants who want to ask the questions. We will have very good discussion upon this topic after the lecture of sir. Over to you, sir, Vijay Kumar sir.
May I start, madam?
Yeah.
Yes. Respected Dr. Karan Kumar Sharma sir, the organizer of the conference series, Dr. Kamini madam, the respected coordinator of the series, then other respected senior faculties all over India, including All India Institute of Ayurveda Delhi and ICRA. Then Dr. Sibiga, the link between Kamini ma'am and me and all other my beloved delegates and participants. I am so happy to join as a part of AYUSH Samriddhi International Conference Series 2020 onward under the Independent Research Ethics Society. I would like to express my sincere thanks to all respected dignitaries. Again, I would like to express my personal thanks to Dr. Kamini ma'am and Dr. Sibiga for their sincere invitation and frequent contact regarding my presentation. Today, I would like to present the topic endometriosis and infertility, beginning with a successfully treated case presentation. Thanks, one and all. Is it visible? The screen is visible? Right. Okay, sir. Right. The case discussion in endometriosis and infertility. Yes. First of all, I am going to present this case. A
Excuse me.
25-year-old woman married since 4 years
Excuse-
with a history of audible.
Yes, your double photo is coming.
Dual
Double
photo.
photo is means
The-
hiding
double
your
photo.
slide. Not
Ah,
text is coming. Half slide is
right, right.
your half slide is visible to your double photo.
Half
Single
slide
photo will be
കാണുന്നു.
on Zoom on YouTube.
Now
Yes,
what about?
yes.
Yeah, it's okay. It's okay. Now it's okay.
Is it okay?
Yeah, now it's
No.
okay.
PPT.
Right.
PPT.
Right.
PPT.
Do you want to put?
Where is your?
Okay, Suresh, welcome.
Okay, okay.
Okay. I am going to present this
Please
topic.
share your PPT. I mean,
Yes.
PPT visible है.
Visible? The PPT is not visible?
No,
PPT is
not to
visible.
me.
I can see.
Okay.
Yes.
Okay.
A 25-year-old woman married since 4
Yes,
years.
right. Correct, exactly.
Severe dysmenorrhea and
Right.
menorrhagia.
This
Yeah.
is the case. A 25-year-old woman married since 4 years with a history of severe dysmenorrhea and menorrhagia came for primary infertility treatment. It was a referred case from a gynec center. USG findings: severe endometriosis with bilateral chocolate cyst. According to medical history, IUI 6 times, hysterolaparoscopy done 1.5 years back for diagnostic and therapeutic purpose for primary infertility. Severe endometriosis, then bilateral chocolate cyst, endometriotic deposit over the uterus and peritoneum, then bilateral admixture adherent to the back surface or the posterior surface of the uterus, the POD obliterated and both tubes patterned. Then the procedures done in that particular hospital, the endometriotic deposit totalized, chocolate cyst dried, cyst was excised and sent for histopathological examination. Then adhesive lysis done, pelvic anatomy restored, and bilateral tube pattern on CPT. Then this is the histopathology result. There is multiple follicle cysts and focus of endometriosis ovary and endometriosis. Again, IUI procedures done, but no positive result. Then she went another gynec center and they referred to me for Ayurvedic treatment. The patient came to me on 21st January 2021. The 31-year-old husband semen analysis done on 7/2/2021. Actually, it was perfectly normal. Then here, all the medical history and investigation reports are attached here with and documented. This is the discharge summary and what are the procedures done there. Then the histopathology report. Then this is the semen analysis report. The volume, liquefaction, viscosity, sperm concentration, motility and morphology, and all parameters were normal. Then the treatment started on here. My treatment started on 21st January 2021. Treatment continued for 1 year. The patient fully cooperated as it is a referred case from a modern gynec center. Then UPT positive on 15 February 2022. LMD was 12 January 2022. EDC 19 October 2022. Then the beta HCG on tested on 16 February 2022. The value of 3000 841 micro international unit per ml. This is the beta HCG report from the lab. Then she delivered a male baby on 15 October 2022 by C-section. The birth weight was 3.1 kg. Since yes. See, it was a well-diagnostic case of endometriosis. You see, endometriosis is a progressive or advancing, ongoing or continuing and long-term gynecological disorder. It is not a serious or neoplastic or killer disease, although malignant transformation is possible. But it has several similarities to malignancy like disease progression, local investment, widespread dissemination. Then what is endometriosis, or how to define endometriosis? It is a peculiar disease of women characterized by the presence of functional endometrial glands and stroma, that is, the endometrial glands surrounded by stroma outside the uterine cavity and musculature, and is responsive to hormonal changes. 1/3 of cases may be asymptomatic, and the majority are symptomatic and cause pelvic pain and infertility. The endometriosis are classified into different groups on different aspects, such as according to the site or location, according to pathology, or according to prognosis, etc. Then, according to the site of endometriosis, the commonly affected sites are pelvic and extrapelvic. The pelvic endometriosis occurs in the pelvic organs and peritoneum, including ovaries, pulse of Douglas, it is the lowest portion of the peritoneal cavity, then broad and uterosacral ligaments, then fallopian tube, then anterior and posterior surface of the uterus, then pelvic side wall, and rarely cervix, vagina, and very rarely in vulva. Then extrapelvic or uncommon endometriosis occurs in any organ system, but is not frequently encountered. Overall, less than 12% of all cases of endometriosis are extrapelvic. The extrapelvic sites are urinary tract, including ureter, bladder, kidney, J tract, including sigmoid colon, rectum, ileocecal area, appendix, and small bowel. Then surgical scars, including cesarean and episiotomy surgical scars. Then thoracopulmonary, lungs and pleura. Then rarely umbilicus and lymph nodes, especially the pelvic lymph nodes. Then coming to the prevalence. The prevalence of endometriosis has been increasing in the present era. It is predominantly found in 8 to 10% of reproductive age group women. The peak incidence between the age of 30 and 40. Between 30 to 50% of women with infertility are diagnosed with endometriosis. Whereas among infertile women, up to 50% of cases, the cause may be endometriosis. It can occur in young girls and rarely perimenopausal age group, but it is extremely uncommon before menarche and after menopause, but it is seen in postmenopausal women receiving hormone replacement therapy. In India, the prevalence is 10%. See, endometriosis is a hormonally dependent disease. That is ectopic or displaced endometrium is responsive to hormonal changes. It is not clear what initiates endometriosis, but estrogen is required for the development of endometriosis. Or estrogen is one of the inevitable factors for the development of endometriosis. Then the growth of endometric tissue regresses in pregnancy due to high progesterone level, in oophorectomy and following pelvic irradiation or following exposure to pelvic irradiation. Though proliferative changes are seen, the secretory changes are rarely seen in the endometriotic bit. This may be due to absence of steroid receptors in the ectopic endometrial tissue. Then If another classification, the endometriosis externa and endometriosis interna or adenomyosis. The presence of ectopic endometrial tissue in sites other than in the uterus, that is other than adenomyosis, is called endometriosis externa, which is generally referred to as endometriosis. Then what is endometriosis interna or adenomyosis? Endometriosis interna or adenomyosis is an ingrowth of endometrium directly into the myometrium. Ingrowth of endometrium directly into the myometrium, and is defined as the presence of endometrial tissues, including penetrating glands and stroma, including penetrating glands. Yes, including penetrating glands and stroma in the myometrium. At least one low-power field, according to some books, at least one high-power field from the endomyometrial junction, or 1 to 2.5 millimeters below the basal layer of endometrium, or deeper than 25% of overall myometrial thickness. Here you can see there is the continuous and irregular endomyometrial junction. This is the endometrium, this is the myometrium, the endomyometrial junction, and the tangential section. And the tangential section may appear as adenomyosis. Totally this appears as adenomyosis, but cannot tell us adenomyosis. There is after entering into the muscular layer or myometrium may be a case of, maybe a suspected case of endometrial carcinoma, and the confirmation depends upon the cell changes. So, with the absence of continuity and with the presence of the endometrial tissues, the penetrating glands and stroma infiltrate into the myometrium as per the above criteria. That is, above criteria means at least one low-power field from the endomyometrial junction, or 1 to 2.5 millimeters beneath the or below the basal layer of endometrium, or deeper than 25% of overall myometrial thickness. See, here you can see the adenomyoma case, the section of the uterus. See, the basal layer of endometrium, including glands and stroma, is seen to infiltrate into the myometrium. The surrounding tissues undergoes hypertrophy and hyperplasia, giving rise to uterine enlargement. That is, the basal layer of endometrium, including glands and stroma, is seen to infiltrate into the myometrium. The surrounding tissues then undergo hypertrophy and hyperplasia, giving rise to uterine enlargement, and shows thickened or bulky and spongy appearance. This is the thickened or the bulky section of the uterine wall. That is effectively myometrium of the uterus. Then, moreover, estrogen receptor mutation means alteration or changing form in the adenomyomatous area, and gene polymorphism also postulated by some scientists without any proof. Then, see, adenomyosis is of two types, diffuse and localized. Diffuse and localized. The diffuse adenomyosis involves anterior and posterior uterine wall and causes uniform enlargement. And usually less than 14 weeks pregnant uterine size. It does not exceed more than 14 weeks pregnant uterine size. The myometrium is thickened and reveal hemorrhagic foci or hemorrhagic localization of adenomyosis form. Here you can see the hemorrhage. See, then localized adenomyosis, which is also called adenomyoma, which is also called adenomyoma. See, it grossly resembles leiomyoma or fibroid uterus, but there is no capsule. They are non-capsulated. See, adenomyoma is non-capsulated, but fibroids are encapsulated. Fibroid comprises or has an outer thick covering or shield. So, adenomyoma is non-capsulated, but fibroids are encapsulated. Here we can see the leiomyoma or the one small fibroid. Here, small fibroid. Then, microscopically, islands of endometrial glands and stroma are found in the myometrium, and which reveal proliferative or hyperplastic or secretory changes. Some of them undergo cystic changes during menstrual cycle, resulting in areas of hemorrhage that can be visualized with the Doppler scan during menstrual bleeding phase, as salt and pepper look. While taking an ultrasonogram or Doppler scan on the bleeding phase, we will get, in such cases, we will get the salt and pepper look. The pepper shape means due to the spiral arterial structure, and the bleeded area resembles salt and pepper look. Then here one thing, I have already told the peak incidence of endometriosis is between 30 to 50 years, but adenomyosis is 40 to, the peak incidence between the age of 40 to 50. And it is commonly seen in multipara, but endometriosis is commonly seen especially in nullipara or having minimal symptoms. Then symptoms may be asymptomatic, and usually secondary dysmenorrhea and menorrhagia are present. Similarly, chronic pelvic pain in some cases. The uterus uniformly enlarged and usually less than 14 weeks size and just palpable abdominally. Next, what are the factors or the factors associated with the increased risk of endometriosis? Factors associated with increased risk of endometriosis. See, endometriosis is common in women with greater exposure to menstruation. Greater exposure to menstruation. Having early menarche and polymenorrhea, means short cycle less than 27 days interval or prolonged duration more than 7 days. Women with shorter interval between menses and longer duration of bleeding are more likely to have retrograde menstruation and a higher risk of endometriosis. This is the relation of menstrual cycle with the forming the risk factor regarding menstrual cycle. Then delayed childbearing, either voluntary or involuntary, in higher income groups. There is late marriage and delayed childbearing, and therefore higher number of menstrual cycles and greater exposure to menstruation. In higher income group, usually they conduct late marriage and also delay the childbearing, or especially the childbirth, and therefore higher number of menstrual cycles and greater exposure to menstruation. Then parity, low parity or nulliparous, there is 50 to 70% of affected women are childless, and many of the others had only 1 or 2 pregnancies. That is, those who have minimal pregnancies are under the risk of endometriosis. Then the social class, higher social class. There are clear national, cultural, and socio-economic differences in pathology. Anovulation and endometriosis are more common in higher social classes in Western whites or the Caucasians, especially Europe and USA, and rarely seen in Negroes and intermediate in Asian women. Endometriosis is described as a disease of the rich because the frequency of disease is reported 4 times in private hospitals. That is why endometriosis is described as disease of the rich. Then genetic factor or the family history. the genetic factor accounts for about 10% of cases. That is, the risk of endometriosis is 6 to 7 times higher if a first degree relative, that is mother or sister, has the degree. Here the influence of maternal ancestry, but in case of polycystic ovarian syndrome, it is related with the paternal ancestry. Then, which is further increased in case of homozygotic twins, there is a possibility of multifactorial inheritance. According to Ayurveda, such conditions can occur due to Bijadosha. Then the body mass index. See, it is also commonly seen in women with the lower body mass index. Those who have lower body mass index, there is chance for endometriosis more. But in case of obese, there is chance of hyperandrogenism, anovulation, oligomenorrhea or amenorrhea, and therefore lower number of menstrual cycles and less exposure to menstruation, such patients having the possibility of polycystic ovarian disease. Then the Mullerian anomalies or obstructive Mullerian anomalies. It is common in women with obstructive Mullerian anomalies and outflow tract obstruction. Women with vaginal or cervical atresia are more likely to have retrograde spill. The incidence rate is high in retroverted uterus. According to Ayurveda, Andarmukhi Yoni Vyapat, having the more chance for retroverted or chance for endometriosis. Then see, the extrauterine endometriosis is often found with a retroversion. For example, it has been found that artificially produced retroversion in menstruating mammals cause the development of endometriosis. Artificially produced retroversion in menstruating mammals cause the development of endometriosis. What are the environmental factors? Well, especially exposure to dioxin. The environmental factor including exposure to dioxin is very important. It is a chemical toxicant which enters the body due to exposure of pesticides in the diet. Dioxin has effects on genes, the reproductive system, and the immune system. Dioxin modulates various hormone receptor systems like receptors of estrogen, progesterone, epidermal growth factor, and prolactin. It shows the immune suppressive activities and is a potent inhibitor of key lymphocytic function. Then the diagnostic modalities, how it is affecting. The incidence is increasing with increasing use of laparoscopic and other diagnostic modalities. Then the possible pathogenic mechanism. This is a severe endometriosis case. Possible endometriosis mechanism. See, once endometrium gets implanted ectopically means this slide. So once endometrium gets implanted ectopically over the peritoneal surface or elsewhere, it starts proliferating with each and every menstrual cycle. More and more deposits grow under estrogenic influence, then they break down and bleed at menstruation. However, there is no outlet for menstrual discharge. When the blood and debris or the blood and the remaining fragments collect within the tissues to form cysts. Then with each menstrual cycle, the collection increases in size, but continual absorption of some of the fluid elements causes blood to become dense or insufficient and dark colored. Gradually, this process ends up in fibrosis around such deposits that cause adhesion and distortion of other organs. Then various theories regarding the development of endometriosis. There is pathogenesis according to various theories. There are various theories regarding the development of endometriosis. Although many theories have been proposed regarding the pathophysiology of endometriosis, no single theory can explain the location of development of endometriosis. See, the different theories, I am not going to explain all these theories in detail, but some. First is the John Sampson's implantation theory in 1921. This is the earliest and most widely accepted classic theory of retrograde spill of endometrial fragments in the menstrual fluid. Well, this is the earliest and most widely accepted classic theory of retrograde spill of endometrial fragments in the menstrual fluid transported through the fallopian tubes into the peritoneal cavity are responsible for the development of endometriosis. A regurgitation of the endometrial fragments through the fallopian tube into the peritoneal cavity can lead to endometriosis. This theory successfully explains the pelvic endometriosis on the dependent portions of pelvis like ovary, cul-de-sac, uterosacral ligament, rectovaginal septum, and posterior surface of uterus. But fails to explain the endometriosis of distant sites like kidney or lung. Moreover, the retrograde menstruation occurs in 80 to 90% of women and is physiological. So, there must be some additional factors. For example, genetic, immunological, or some other favorable factors that induce the growth of these endometrial cells in the ectopic location in some women, but not in others. So, there is also a strong support or support from the genetic or immunological or some other favorable factors that induce the growth of these endometrial cells in the ectopic location in some women, but not in others. Otherwise, the retrograde menstruation occurs in 80 to 90% of women. We can't consider as physiological one. Then the second theory, coelomic metaplasia theory. Metaplasia means the transformation of one type of tissue into another, and the other is the histogenesis or the tissue differentiation by induction theory. Then next one is very important, the venous and lymphatic dissemination or metastatic. Venous and lymphatic dissemination or metastatic or spread theory. According to this theory, the occurrence of endometriosis of distal organs like vulva, vagina, cervix, gastrointestinal tract, lungs, pleural cavity, umbilicus, cervical sacs, and lymph nodes is due to the embolization of endometriotic tissue via vascular and lymphatic channel dissemination. Distant areas, the development of
Your voice is not coming, sir. You're not audible.
Is there any problem, doctor?
Not audible.
Not audible.
He is muted.
You are mute. Please unmute. Please unmute. Yes.
now audible or not?
Now
Yes,
audible.
yes,
Now
yes.
audible.
Your presentation
now?
is not visible.
Not visible. This area, now I am dealing with this area. Is it visible?
Yeah, visible.
Hello?
Yeah, visible.
Audible?
Yeah, audible, visible. Fine.
Yes, thanks a lot. Okay. So immunological factors theory. See, now, okay? Yes, the immune system may be altered in women with endometriosis. The endometriosis can also consider a condition of immunological tolerance there is decreased cellular immunity to endometriotic tissue. This results in reduced clearance of shed endometrial cells from the peritoneal cavity. So, there is the immune system may be altered in women with endometriosis, which results decreased cellular immunity to endometriotic tissue. The immunological changes may also cause an alteration in the function of macrophages. That is, T and B lymphocytes can be recruited by the activated macrophages, which secrete the cytokine and growth factors that enhance the implantation of endometrial cells and the development of endometriosis. So the immunological changes may cause an alteration in the function of macrophages, where T and B lymphocytes can be recruited by activated macrophages, which secrete. These particular T and B lymphocytes secrete cytokines and growth factors that enhances the implantation of endometrial cells and development of endometriosis. Genetic factor, I have already told, it accounts for about 10% of cases. Then the molecular defect. Molecular defect means hormonal dependent. Estrogenic influence is essential for the development and continued activity of ectopic endometrium. The endometrial implants have been shown to express the aromatase enzyme, express the enzyme aromatase. Aromatase enzyme is arising from the endometriotic implant. Then, this is responsible for the conversion of androstenedione to estrone and estrone to estradiol respectively. See, the molecular defect means hormonal dependence. Estrogenic influence is an unavoidable thing. Estrogenic influence for the development and continued activity of endometriosis or endometriosis. Then endometrial implants have been shown to express the enzyme like aromatase, which is responsible for the conversion of androstenedione to estrone and estrone to estradiol. Then the new here research has now revealed that several biologically active substances are produced in the ectopic endometrial tissue. That is, several biologically active substances are produced in the ectopic or displaced endometrial tissue that are responsible for various stages in the development of endometriosis from implanted endometrium. Then what are the substances? Biologically active substances produced in the ectopic endometrium are one, cytokines. Cytokines I have already told from activated macrophages, which is responsible for the implantation and the adhesion of endometrial tissues to the peritoneal surface. Then matrix metalloproteinases, which is responsible for inversion. What is matrix metalloproteinases? A group of enzymes which inhibit the establishment or abolishing of ectopic endometrial tissue and thereby extracellular matrix turnover in patients with endometriosis is altered. The extracellular matrix turnover increases because the presence of matrix metalloproteinases, a group of enzymes which inhibit the establishment or the abolishing tendency of the ectopic endometrial tissue and which is responsible for the inversion or responsible for the invasiveness of the endometrial tissue. Then vascular endothelial growth factor, which is responsible for angiogenesis or new vessel formation. Vascular endothelial growth factor A. The endometrial tissue develops its own vascular supply. And an independent forming an independent growing mass, so-called angiogenetic disease. It is also called angiogenetic disease because the endometrial tissue develops its own vascular supply and become an independent mass. The endometrium itself is a rich source of growth factor which promotes angiogenesis. Then next, growth factor, which is also secreted by the activated macrophages, responsible for further growth and development of endometriosis. Then estrogen is inevitable thing which is responsible for the proliferative changes of the endometrial tissue. And finally, the prostaglandin, which promotes inflammatory reaction. Moreover, the production of these substances could be genetically determined because immunological and genetical factors also determine the survival of regurgitated endometrial cells. And adjacent to the peritoneal surface and growth, because retrograde menstruation occurs in 80 to 90% of women and is physiological, but endometriosis develops in some women only and not in others. The mechanism currently proposed pathogenesis, they see all these factors take part in the development of endometriosis. The genetic, immunological, molecular development, hormonal influence, and mechanical factors like retrograde menstruation. Under the influence of biologically active cytokines, there is implantation of ectopic or displaced endometrial cell and adjacent to the peritoneal surface. Then vascular endothelial growth factor A promotes angiogenesis. And the growth factor promotes growth of endometrial cells. Then estrogen promotes proliferative endometrial or changes. Then prostaglandin promotes inflammatory reaction, and finally ends in endometriosis. Then our perspective, the pathophysiology according to Ayurveda. See, here the genetic factor or Bijadosha, environmental factors, Mithyahara and associated immunological tolerance. Then mechanical factors under the role of Andarmukhi Yoni and Udavarta. See, no single disease can explain the condition of endometriosis. Yoni rogas like Andarmukhi, Udavarta, and Vadigi. And the another disease, the Vadaja Granthi, are the responsible conditions for the pathophysiology and various stages of development of endometriosis. Andarmukhi Yoni closely resembles to retroversion. Due to the involvement of Vada, retroversion favors Vimarga Gamana Krododusti and retrograde menstruation, that is regurgitated Ubadhadu Artava, leading to the condition of Udavarta. The genetic factor Bijadosha is one of the favorable factors in some women responsible for the development of endometriosis. Then, due to the association of kapha, there is adhesion, growth, and proliferation of implants on the peritoneal surface. On the basis of clinical features, Vadigi Yoni, they have exposed the symptoms of endometriosis like stiffness, roughness, fatigue, lethargy, Soda, Vedana, Stambana, and chronic pain on the pelvis. Then the areas like the flank or inguinal region. Then old and long-standing lesions have a similar lakshanas of Vadaja Granthi with the formation of endometriotic cyst. If not properly treated in the early stage itself, there is angiogenesis and inflammatory reaction due to the association of pitta along with dhatu recta. Then Resta and Rekta Dhatu promote vascular and lymphatic spread and development of endometriosis in the extra-pelvic side and complicated to the lakshanas of Astridhara. You know the complications of any Astridha, Asto, Gulma, Deen, Avada, Anilagati. So, the Resta and Rekta Dhatu promote vascular and lymphatic spread and the development of endometriosis in the extra-pelvic side and complicated to the lakshanas of Astridhara or menorrhagia or polymenorrhagia. Then Asta and Gulma, rectal involvement causes painful defecation, stricture or constipation. Finally, with the involvement of all the three doshas, extra-pelvic endometriosis can occur in any organ system, that is Abhadamsa Anilavisi, but not frequently encountered. Adenomyosis due to the involvement of Mamsadhatu in the uterine wall. Again, due to the involvement of Sukradhatu and Sukravahas, the ultimate complication, infertility may result. And very rarely, the malignant changes can occur with favorable prognosis. Then another classification is there. Endometriosis are classified into different groups and different aspects I have already told. Then this is the pathological classification and along with the macroscopic appearance. The pathologically endometriosis are classified into three groups: superficial endometriosis, ovarian endometriosis, and deep infiltrating endometriosis. The superficial endometriosis, then ovarian endometriosis, and deep infiltrating endometriosis. See, the superficial endometriosis, it is also called peritoneal endometriosis. The lesions are usually in the dependent portion of pelvis. The most common sites are the surface of ovary, usually involving both sides. Then the pelvic peritoneum over the anterior and posterior surface of uterus, south of the glass, broad and uterosacral ligament. The deposit may also be seen on the cervix, vagina, and rarely vulva, or the pelvic organs and peritoneum. The pelvic lymph nodes are also involved in some extent, or 30% of women. See, macroscopic or gross appearance of superficial endometriosis varies depending on whether the lesions are airy and recent. Macroscopic or gross appearance, we can find out the airy and recent, or the endometriosis, whether the endometriotic lesions are airy and recent or old and long standing. Airy lesions are pink, red, or hemorrhagic and become brown or bluish black. Bluish black means the powder burn appearance. And puckered means wrinkled or extensive scarring with time. Then gradually the old and long standing lesions, the discoloration disappears and the lesion appears white and fibrotic. So gradually the discoloration, there is color change, and or the color or all the above colors disappears and the lesion appears white and fibrotic. The superficial endometriosis cannot be palpated on clinical examination, but they are also difficult to visualize on imaging or with ultrasound or MRI, and the diagnosis is only by laparoscopy. Then ovarian endometriosis. They are also called ovarian endometrioma, and it is differs from superficial ovarian endometriosis. But superficial ovarian endometriosis, one of the important sites is ovary, at which the endometriotic deposits are seen only on the surface of the ovary. Then here the ovarian endometriosis or endometrioma, how the endometriosis appearing inside the uterus, inside the ovary. Here, everybody know the pseudopodia and foot vascule of the amoeba. Here, the inversion and invagination of the ovarian cortex with the superficial endometriotic deposit. Inversion and invagination of the ovarian cortex with the superficial endometriotic deposit is said to cause this deep lesion or cyst, which gradually enlarge and are filled with old blood. Thus, the ovarian endometriosis or endometrioma or the chocolate cyst is formed. Grossly endometriosis are located on the antemesenteric surface of the ovary. Then here see, one lab can be detected on pelvic examination, on laparoscopy or laparotomy. The size is no more than or always less than 12 centimeters in diameter and adherent to the posterior peritoneum or attached to the pelvic side walls or the posterior surface of the broad ligament and posterior surface of the uterus. Retraction of the ovarian cortex is also visible there. Then powder burn or blue-black spots on the ovaries also can see. Then it is filled with tarry, thick, chocolate-colored fluid, so-called chocolate cyst. This is the picture of chocolate cyst or the ovarian endometrioma. The last one is deep infiltrating endometriosis, which is also called posterior pelvic endometriosis. The lesions extend more than 5 millimeters beneath the peritoneum. More than 5 millimeters beneath the peritoneum, usually located in the rectovaginal space. Rectovaginal space, but may involve the uterosacral ligament, cervix, bowel, then ureter. The lesions cause inflammatory reaction and adhesion formation and can mimic malignancy very rarely. This lesion, the lesions of the deep infiltrating endometriosis can be felt on pelvic and rectal examination are tender in duration. Tender in duration means tender hardening and nodularity or small nodes. They can also visualize on imaging, but the extent or depth cannot be assessed by laparoscopy. This is the microscopic appearance, the microscopic appearance of endometriosis. See, microscopically, we can see the endometrial glands and stroma, and also hemosiderin-laden macrophages. The hemosiderin-laden macrophages, or evidence of chronic hemorrhage, or due to the presence of blood consumed and enlarged macrophages are these. These are the blood consumed and enlarged macrophages. See, the glands may reveal proliferative or rarely secretory activity. Deep infiltrating lesions are surrounded by fibrous and smooth muscle tissue in women with endometriosis of long duration, where the typical endometrial glands and stroma may not be present. See, on the basis of microscopic appearance, at least two of the following three microscopic features should be present. That is, endometrial type gland, endometrial type stroma, or evidence of chronic hemorrhage or hemosiderin-laden macrophages. Where any two factors should be present, and the positive histology confirms diagnosis, but the negative histology does not exclude it, because the deep infiltrating lesions are usually surrounded by fibrous and smooth muscle tissue, cannot be identified as the typical features of endometrial glands and stroma. Then risk of malignancy in endometriosis. See, very rarely ovarian clear cell carcinoma and the endometriotic carcinoma can develop in endometriosis. Therefore, the endometriosis in perimenopausal and postmenopausal age should excise or removed completely when the surgery is undertaken. When the surgery is undertaken, in case of perimenopausal and postmenopausal age group women, if the patient is affected by endometriosis, should be excised completely. Since malignant transformation seems to be estrogen dependent, estrogen replacement therapy should be administered under supervision, under very good supervision in postmenopausal women with non-endometriosis, because it is always a estrogen dependent disease. Then the cancer biology, though endometriosis is no longer considered as a malignant disease, there is very few chance for adenocarcinoma or other malignant diseases arising in an island of endometriosis. And endometriosis, if there is an endometriosis associated ovarian cancer, it has better prognosis. Therefore, don't worry. The development of malignant diseases are reported in endometriosis of rectovaginal septum, then ovaries, bowel, and cervix, and also uterine adenomyosis. Very minimal cases were reported. Then the diagnosis of disease. Diagnosis, the symptoms associated with endometriosis. See, diagnosis of endometriosis is made on the basis of history, physical findings, and investigations. Endometriosis should be suspected in a woman with infertility, dysmenorrhea or dyspareunia, and cyclical or acyclical chronic pelvic pain. See, one-day cases may be asymptomatic. Then adnexal tenderness already told, adnexal tenderness or adnexal masses or tenderness and nodularity over the uterosacral ligament can be suggestive of endometriosis, such cases. Then, moreover, symptoms are not related with the extent of lesion. The depth of penetration is more related to symptoms rather than the spread of lesions. Greater than 5 millimeters beneath the peritoneum are responsible for pain. For the pain, dysmenorrhea and dyspareunia. Non-pigmented lesions produce more pigment, non-pigmented lesions produce more prostaglandin, that is PGX2 alpha than powder bands, and are more painful. A more certain diagnosis is the direct visualization of lesions during laparotomy or laparoscopy, but histologic diagnosis of biopsy specimens has been the gold standard for diagnosis. The symptoms with the endometriosis include pain, disorders of menstruation, cyclical bladder bowel symptoms, then general ill health or chronic fatigue and other symptoms, and finally infertility. The most important thing is pain. The pain, dysmenorrhea, which is severe, dyspareunia, dysphagia, dysuria, dull ache of abdomen. It can be described as 5 Ds. 5 Ds. Dysmenorrhea, dyspareunia, dysphagia, dysuria, dull ache of abdomen, in addition ovulation pain or chronic pelvic pain. That is painful menstruation, painful coitus, painful defecation, painful urination, dull ache of abdomen, and painful ovulation and chronic pelvic pain. Or chronic pelvic pain is the acyclical pelvic pain, are commonly associated with endometriosis. Then the first one is dysmenorrhea. Here the dysmenorrhea is usually secondary, secondary to pelvic pathology or congestion. The pain starts few days before the onset of bleeding phase. Few days before the onset of bleeding phase, that is during the secretory phase itself, and become progressively or severe near and during menstrual period, and extends for 1 or 2 days into the post-menstrual phase. The pain worsens progressively with the duration of disease and is very severe, causing incapacitation and does not respond with simple analgesic. The pain will be very, very severe. Then, you know, the dysmenorrhea is caused by in the primary and secondary. The primary dysmenorrhea is caused a few years after menarche, when the ovulatory cycles are established. The pain is the primary dysmenorrhea, the pain is suprapubic and radiates to the back and thigh. It is associated with nausea, vomiting, and diarrhea. That is, the associated symptoms of primary dysmenorrhea is always related with the alimentary system, and usually subsides before the age of 20 itself, but secondary dysmenorrhea occurs several years after menarche, that is above 20 years, secondary to pelvic pathology, like endometriosis, adenomyosis, chronic PID, cervical, then the cervical stenosis or fibroid uterus, ovarian mass, etc. Then what is dyspareunia, which is referred to as the pain before, during, or after sexual intercourse. It is traditionally classified into superficial and dyspareunia. Pain that occurs at the introitus during insertion or in the mid-vagina is superficial. This occurs due to the painful lesion in the vulva or vagina. But deep dyspareunia is due to painful lesions in the pulse of Douglas or uterosacral ligament and experienced during deep penetration. The process may be endometriosis, chronic PID, then acutely retroverted uterus, adnexal pathology, etc. In endometriosis, the dyspareunia is usually deep in the pelvis. It is usually due to the direct contact tenderness or direct pressure on the pouch of Douglas or stretching of uterosacral ligament. The involvement of endometriotic implants in the POD and uterosacral ligaments may produce nodular thickening and softening of uterosacral ligaments, which in turn leads to further stretching during intercourse. Then dysphagia or painful defecation along with irritation, diarrhea, bleeding, melania, means discharge of tarry bloody stool are caused by direct involvement of rectum, rectal stricture, or abnormal contraction of anal prostate can cause constipation, and this condition may stimulate very rarely rectal carcinoma. Then dysuria or painful urination. Frequency, what is frequency? Frequency of urination means occurring at short intervals. Urgency means immediate need. Then the frequency, pain, and cyclical hematuria are observed due to bladder involvement. The causes of pain in endometriosis. Well, what is pain? You see, according to International Association for Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It is an unpleasant sensory and emotional experience associated with actual tissue damage or potential tissue damage. First tissue damage causes acute pain, but chronic pain continues long after the tissue injury heals. The pain perception involves peripheral and central nervous system and is influenced by so many factors like social, psychological, and environmental factors. And various modulators like prostaglandin or vasopeptides and endorphin, etc., also play a role in pain. The causes of pain in endometriosis include peritoneal inflammation due to the presence of prostaglandin, then activation of non-receptors or the pain receptors, nerve irritation with the deep infiltration, then tissue damage, actual or potential tissue damage, then local production of prostaglandin, adhesion formation, and collection of blood in the endometriotic implant. Next is the disorders of menstruation, including menorrhagia and the premenstrual spotting, are usually due to associated anovulation and abnormal follicular development, and pelvic congestion or intermenstrual pelvic congestion. Then intermenstrual bleeding is due to cervical or vaginal lesion. Then cyclical bladder syndrome. Cyclical hematuria is more common, but cyclical bleeding from the rectum is less common. Then coming to our main topic, infertility. See whether endometriosis causes infertility or vice versa is not clear. Endometriosis can lead to infertility. Similarly, infertility can lead to endometriosis. The prevalence of endometriosis is 30 to 50% in infertile women. There are several mechanisms by which endometriosis leads to infertility. The mechanisms by which endometriosis leads to infertility include one, ovulatory dysfunction, that is abnormal follicular genesis, can lead to decreased AMH and andral follicle count. Then anovulation may be due to altered LH. There is always chance for inadequate or dual LH that may lead to anovulation. Then luteal phase defect, everybody knows, inadequate progesterone production during the post-ovulatory phase or inadequate progesterone support in the post-ovulatory phase may result in fertility or early pregnancy loss. Then luteinized unruptured follicle syndrome or LUS syndrome. The dominant follicle undergo luteinization without rupture and release of ovum. Undergo luteinization without rupture and release of ovum. The pregnancy cannot occur, but progesterone production occurs. This condition is very rare, but seen in some women with endometriosis. Most probably, it can be corrected with the lesinexira. As far as IRES is concerned, lesinexira and Jiragarista are the drug of choice for LUS, luteinized and unruptured follicle syndrome. Then immunological alterations or altered immunity and decreased sperm survival. Increased or decreased secretion of various cytokines that due to the activation of the macrophages. The immunological process has been found to alter among women with endometriosis. These changes may affect sperm egg function, the survival or embryo development. The immunological changes may also cause alteration in the function of macrophages. I have already told that is T and B lymphocytes can be recruited by activated macrophages, which secrete cytokines and growth factor that enhances the implantation of endometrial cells and development of endometriosis. So it can alter or it directly affects the sperm expansion, the survival, and the embryo development. Then the peritoneal factors, there is intraperitoneal inflammation and local production of prostaglandin. It is very important. The intraperitoneal inflammation, there may be increased peritoneal fluid volume, increased peritoneal fluid WBC concentration, then increased production of inflammatory cytokines, then growth factor and angiogenesis promoting factors. It has been found that there is an increase in number of leukocytes in infertile women with endometriosis as compared with the fertile women. See, there is an increase in number of WBCs in infertile women with endometriosis as compared with the normal fertile women. Then interference with implantation. See, there may be endometrial dysfunction in women with endometriosis. The endometrial receptivity depends on endometrial thickness, endometrial pattern, and blood flow in the spiral arteries. Endometrial thickness between 9 to 12 millimeter in the pre-ovulatory period is associated with higher pregnancy rate. The pre or late proliferative phase, it should be between 9 to 12 millimeter thickness. At the same time, the endometrial thickness more than 15 millimeter is also not suitable for implantation. Then the typical three-layered or triple line pattern of proliferative phase endometrium to be more predictive of implantation. Likewise, adequate blood flow in the spiral arteries promotes implantation. All these factors can alter with endometriosis. Then the mechanical factors, there is anatomical obstruction of the tube, interference with the ovum pickup, altered tubal motility, peritubal adhesion. It has been found that endometriotic tissue as well as normal endometrium produces prostaglandin. Now, the endometriotic tissues as well as normal endometrium produces prostaglandin, which may adversely affect the ovum pickup or tubal motility even in the absence of obvious impairment by adhesion. Then interference with the coital function, that is, deep dyspareunia may interfere with the coital function. Then sperm inactivation, that is phagocytosis by macrophages or inactivation by antibodies. Inactivation by antibodies, phagocytosis by macrophages. Enhanced macrophages by or enhanced phagocytosis by macrophages and natural killer cells. Everybody knows the NK cells, which may enter the sperm and ovum. The macrophages or now huge amount of macrophages and natural killer cells can enter the sperm and ovum. Then inactivation by antibodies. It has been suggested that endometriotic implants may secrete substances that interfere with the normal sperm motility and thereby impair the process of fertilization. Then clinical diagnosis of endometriosis. The physical examination may not reveal any abnormalities in women with minimal superficial endometriosis, and large and advanced lesions can be detected on examination. The abdominal examination, the mass arising from the pelvis can be located in the iliac fossa. Then the tender, the feeling of tenderness and is not freely mobile. Then speculum examination, the vaginal lesions may be seen as bluish spots or nodules in the posterior fornix. Usually it is visible. Then pelvic examination reveals fixed retroverted uterus, because there is always chance for softening of the uterosacral ligament, which leads the underverted uterus to retroverted in majority or major cases of endometriosis. So one pelvic examination, the fixed retrovertebral uterus can find out. Then the adnexal mass, maybe unilateral or bilateral. Then adnexal tenderness and tender uterosacral ligament and tender nodules in the POD or the pouch of Douglas. Then cervical or rectovaginal examination. Rectal examination is required if the rectal symptoms are present only. There is tenderness in the pouch of Douglas or tender nodules in the pouch of Douglas. The imaging or the role of ultrasonogram. Imaging is of limited value in the diagnosis of endometriosis, except in ovarian endometriosis. Endometriosis or ovarian endometrioma. Ovarian endometrioma more than 2 centimeter in size can be diagnosed on transvaginal ultrasonogram and appears as cystic mass with a low level internal echo with or without internal separation and the hyperechoic foci in the wall. Then MRI is also not useful in superficial endometriosis and less accurate in the diagnosis of deep infiltrating endometriosis and is useful only in ovarian endometrioma less than or more than 1 centimeter. But ultrasound more than 2 centimeters can be diagnosed. The rectovaginal nodules can be identified, then the evaluation of extensive endometriosis also can identify. Then CA125. CA125 is the tumor, one of the tumor markers. The tumor markers like CA125, alpha-fetoprotein, and the lactodehydrogenase are useful in the diagnosis of malignant ovarian tumor. CA125 is a tumor marker for epithelial ovarian cancer. The levels are elevated in endometriosis but vary widely. Therefore, it is not a diagnostic tool in endometriosis that may be used to detect recurrence after surgery. The level of 35 units per ml is used as cutoff for the diagnosis of malignancy. Previously, the cutoff value 35 units per ml. But this marker is elevated in several benign or mild gynecological conditions like endometriosis, PID, abdominal or genital tuberculosis, leiomyoma, and pregnancy. Such conditions also, the CA125 is increasing above the level of 35 units per ml. Since all these conditions are encountered in premenopausal women, all these conditions can occur in premenopausal women. So the test is not as useful in postmenopausal women. A cutoff value of 200 units per ml is therefore used in premenopausal women for the diagnosis of malignancy, and a cutoff value of 35 units per ml is used for the diagnosis of endometriosis or diagnosis of malignancy in postmenopausal women. Then role of laparoscopy. The visceral inspection of the pelvis at laparoscopy can be made a more certain diagnosis of endometriosis. The laparoscopy is useful for the diagnosis or obtaining samples for histology and even for therapy or intervention is required. Then what is the role of biopsy? Biopsy should be taken when the ovarian endometriosis is more than 3 centimeters in diameter and in deep infiltrating disease to confirm diagnosis and exclude the rare possibility of malignancy. Then staging of endometriosis. Staging of endometriosis. Stages, 4 stages, sometimes some, according to some books, 5 stages. The staging of endometriosis is by revised American Fertility Society classification, which is also adopted by the American Society for Reproductive Medicine. The points are allocated for endometriotic lesions peri-ovarian adhesion and pouch of the glass obliteration. The disease is stage 1, minimal, where the score 1 to 5, stage 2 mild, score given 6 to 15, then stage 3 moderate, score 16 to 40, and stage 4 is severe, more if the score is more than 40. Then the management, see, there is no permanent cure for the endometriosis. The best available management is, according to modern, this is not important for us. So the best available management is bilateral oophorectomy. This is not acceptable in young infertile women. Other short-term goals of treatment are relieve pain and improve fertility. The long-term objectives are the prevention of disease progression and recurrence after therapy. Modern medical management or modern management may be medical or surgical. The medical management, I am giving the name only. This is not at all important. The new medical, on the base of new medical approaches for the medical treatment, the endometriosis has been mainly hormonal with a view to suppress the estrogen production. That is why they are giving selective progesterone receptor modulators, GnR and antagonists, then aromatase inhibitors. Aromatase, aromatase enzyme convert androstenedione to estrone, then estrone to estradiol. Then tumor necrosis factor alpha inhibitor, then angiogenesis inhibitors, matrix metalloproteinase inhibitors, the enzymes I have already told, then immunomodulators, then estrogen receptor B antagonist, estrogen receptor, beta estrogen receptors and alpha estrogen receptors that everybody know is beta receptors are located in the female reproductive system and the breast. Then alpha is located in bone and ovary. Then the selective estrogen receptor modulator. Then surgical management. Here also just giving the name. The surgical management, the conservative surgery, cauterization of lesions, then laser vaporization of lesions. Just for your interest, I am giving this name. Cauterization of lesions, laser vaporization of lesions, laparoscopic uterosacral nerve ablation, adhesive cyst aspiration and irrigation, cystectomy, and then vaporization of inner cyst wall and the excision of rectovaginal nodules. And radical surgery include hysterectomy with bilateral salpingo-oophorectomy, with or without ball resection, and with or without ureteric resection and anastomosis or re-implantation. Then sadhya asadhyatva according to our science. Once considering the involvement of all the three dosas, progressive, ongoing, long-standing nature, and complications, the prognosis becomes sadhya, yapya, or asadhya. See, long-term oral route administration of Ayurvedic medications are effective in both pelvic and extrapelvic endometriosis. Anal route, this is also part of the enteral route. Enteral route means placement of drugs in any part of the alimentary tract is enteral. And vaginal is the topical route, that is local route. So anal or enteral route and vaginal or topical route administration of the selective Ayurvedic formulations are more effective and useful in rectovaginal endometriosis, also superficial endometriosis, and recurrent endometriosis after surgery. There may be significant relief of pain, especially dysmenorrhea and dyspareunia with our medicine. Then the medication for Snehabana. Here, first one is Karpasa Tyaditaila. WHO accepted the cottonseed oil for endometriosis. WHO itself accepted years back. Then Mahanarayana Taila, Satapuspa Taila, Dhanundaram Taila, and Gulgulu Tiktaga Hirda. This Gulgulu Tiktaga Hirda I have already used. Preconceptionally I have used because the Gulgulu Tiktaga, these things, see, the inflammation plays the major role in the pathogenesis of endometriosis. Medications described in the Vata Shonita conduct, that is for inflammatory conditions, can be incorporated. That is why I use the Gulgulu Tiktaga for the management. Management means given preconceptionally for the sustenance of endometriosis. The case I have beginning with the case discussion. Then for Sodhana, Virajana, here the Vadasamana Virajana is very important. With the choice of drugs, Gandharvaranda or Hingatragana, I have used a Hingatragana given preconceptionally as Vadasamana Virajana. In case for Chittasamana, Albachichurna is better. Then Astavana, Anuvasana, and Uttaravasti, Karpasasti Taila can be used. Dhanundaran Taila, Palasarpis, and Gulgulitikta can be used. I have used for that particular case the Dhanundaram Taila for especially for Anuvasanavasti. I haven't given the Uttaravasti for that particular case. Then oral drugs, the highlighted items are given to that particular patient. The Trayanjari Kasaya given preconceptionally, then Indiganda Krida given antenatally. In the later half, after 20th week of pregnancy, I have the Indiganda Krida for getting immunological modulation. Then the Gulgulu Tikta Krida given preconceptionally. Then Jivandyadi Krida, Nimbadi Kasaya also you can advise. Then Belakira Kasaya, I advise antenatally. It is very important for pregnant ladies. Bela prepared in milk. Then Saptasara Kasaya, Tikta Krida, Tadavariyadi Krida, Tirabala, etc. can advise. I have advised Dhanundaran Gulika also given antenatally. Then Gulgulu Panchapartuna you can give for preparatory purpose or for endometriosis. Then Palasap is also given antenatally. Then what are the things to be avoided and to be advised? Avoid Mata, Tila, Soya, Surana, Kumari, and broiler chicken should be avoided because all are phytoestrogenic. Then estrogen is the inevitable factor for the development of and prolonged activity of endometriosis. So you should strictly avoid Mata, Tila, Soya, Surana, Kumari, and broiler chicken especially. Then you can advise Bela, Hira, Sabira, Gopsida, Amalaji, Malsya, and Curcumin. See, evaluation and management of endometriosis should be directed towards prevention or at least limiting adverse outcomes. Successful spontaneous pregnancies occur in minimal, mild, or moderate endometriosis after Ayurvedic medical treatment. Then thank you, one and all.
Thank you, sir. It was really very nice lecture. You have compiled each and everything in your lecture and you have presented with all enthusiasm. It was really nice. Thank you so much.
Thanks a lot, madam.
Yeah. Now we will take up questions. If anyone want to ask, they can ask the question. Otherwise, I'll ask.
Okay. I think it was a lengthy one. Then only I can complete or cover almost all the items briefly.
Yeah, very nicely covered. Everything you have covered. Even NK cell theory also you have covered. It is yeah, it is latest theory, NK cell theory. Yeah.
Natural killer cell. Which can end this sperm or
and natural killer cell theory is very latest and Ayurvedic theory is giving very good result in that theory. Natural killer cell, yeah, yes.
We can see higher WBC count in infertility patients associated with this endometriosis when comparing
Yeah.
with the normal infertility patients having no endometriosis.
Yeah.
You can check
Yeah.
for WBC count.
Yeah.
So we can definitely confirm it is highly inflammatory state.
Nice. And what about Addison's? Lot many patients are having Addison's and
Yes, lot of patients are coming for the treatment of endometriosis. I have successfully treated number of cases. Just one case for your interest I told here. Number of cases are referred from so many allopathic modern gynec centers.
yeah, yes.
I am proud of that.
Yes. They are not
So
having
many,
answer. They don't have answer of this, so they are sending the patients to us that what to do in this case. Yeah, that is the thing. Yeah. Anybody want to ask the question?
Good evening, ma'am.
Good evening, Pawan ji, पूछिए.
Good evening, ma'am. सबको सादर चांस बस थैंक्स टू सर. उनका जो प्रेजेंटेशन था बहुत एनर्जी वाला था. सर से मेरा 2-3 क्वेश्चन है. सर, जो इम्यूनोलॉजिकल थ्योरी में आपने बताया टी लिम्फोसाइट्स वगैरह जो एक टॉपिक उसमें एंडोमेट्रियोसिस में ज्यादा हमें वो करते हैं, डिस्टर्ब हो जाते हैं, तो हम आयुर्वेद तरीके से उसको कैसे कोरिलेट करेंगे? एक क्वेश्चन, फर्स्ट क्वेश्चन ये है. दूसरा क्वेश्चन सर, आपने हमें बताया जो बायोलॉजिकल एक्टिव सब्सटेंस रहते हैं उसमें जो एक्टोपिक एंडोमेट्रियोसिस का काज बनते हैं, उसमें आपने एंजियोजेनेसिस बताया जो उसमें, तो उसको हम पित्त धातु, पित्त और रस धातु रक्त का इन्वॉल्वमेंट आपने बताया. अगर हम उसको अर्ली डिटेक्ट करना तो हमें क्या क्या पेशेंट में सिम्टम्स मिलेंगे? थर्ड 2 क्वेश्चन और बाद में पूछता हूँ सर.
Immunological factors, the Vedic Samatva will destroy. Endometriosis cases.
हाँ सर, इम्यूनोलॉजिकल अगर हम आयुर्वेदा तरीके से हम लोगों में अवेयरनेस फैलाना चाहे. एक मिनट सर, मेरा क्वेश्चन पूरा न दो. इम्यूनोलॉजिकल जो थ्योरी आपने बताई है जिसमें टी सेल्स जो हमारा डिस्टर्ब हो जाता है, अगर हम अर्ली स्टेज में हम आयुर्वेदा कोई कैंपेन करना चाहे, जैसे हम स्कूल में कोई लेक्चर देना चाहे बच्चों को, तो उसमें ये फैक्टर किसी को प्रभावित ना करें, उसमें आयुर्वेद तरीके से हम क्या बच्चों को हम क्या कैसे बताएंगे, उसको आयुर्वेदा से कैसे कोरिलेट करके बताएंगे, ताकि ये फ्यूचर में बच्चों को, जैसे हम 10th क्लास के बच्चों को ये किसी स्कूल्स में लेक्चर देने के लिए जाते हैं आयुर्वेदा की अवेयरनेस के लिए, तो हम उसको कैसे कोरिलेट करेंगे, बच्चों को कैसे हम समझाएंगे ये फ्यूचर में प्रॉब्लम ना हो?
Sir, I am Hindi only Dhoradora madam. Sir, if possible, bring in English, but I can answer for this particular question.
Sir,
We are giving Ayurveda medicine, meaning immunomodulators. In early stage, we are giving, or the beginning stage, we are giving anti-inflammatory drugs, the drug of choice, Tikta, Hruda, Mahatikta, Hruda, Gulgulu, Panchavada, etc. Followed by we are giving Induganda Krida. It is described in the Rajasma Prajarana in order to maintain or activate our immunity. It will definitely resist and prevent the implantation and the further development of endometriosis. If there is any possibility of activation of T or B lymphocyte, that particular T and B lymphocyte produce the growth hormone, which is responsible for the development of endometriosis. If there is no inflammatory tendency and
stop screen sharing, then it will be good. Stop screen sharing. Yeah. Screen share stop. So you will be visible in full screen. Yeah.
Yes. Then, yeah. full screen to visible me.
Yeah.
Yes.
Yes.
Can you see me? Yes.
Yeah.
Yes, sir.
Right.
बहुत ही शानदार प्रेजेंटेशन था कामिनी जी,
Right.
बहुत
Right.
ही।
Right. So,
Okay.
नमन
first
नमन
of
आप
all,
जुड़ते रहा करें।
we have to bring anti-inflammatory drugs, or we are aiming. That is why the what are the drugs described in the Vadastonida conduct? One of the most important formulation is the gulgulipictazida. It is highly effective in endometriosis cases in the beginning or moderate or advanced stages. Then we have to suppress the inflammatory changes first. Then followed by we have to enhance or raise the immunity. Immunity, you can cover the immunity or reach the immunity to the optimum level with our Indikanta Krida. Indikanta Krida, you should advise at least 1.5 or 2 months regularly. Then with the immunity, now there is no need for NK cells or T lymphocytes or B lymphocytes. Means there is no inflammatory tendency, means no WBC in the out of the vessel.
Thanks, sir. My second question is, sir, how we correlate molecular defect theory in Ayurveda?
Yes. Molecular defect is the hormonal thing. See, so many medicines have estrogen-like action and progesterone-like action. Progesterone-like action. See, one of the main examples for a drug having estrogen-like action is Sukumarakirda. Sukumarakirda provides estrogen-like action. We can definitely substitute that wherever estrogen is in need, the Sukumarakirda. But Palakarpi has the progesterone-like action. Progesterone-like action, then the Kira, the Bala Kira Visaya, it is also having progesterone-like action. Similarly, the Dhanandaran Gulika has progesterone-like action. All these, normally the estrogenic influence can inactivate with the administration of progesterone. See, so endometriosis is one of the hyperestrogenic state where you should strictly avoid the Sukumara combinations of Sukumara Kasaya or Sukumara Hirda or anything. But you can definitely advise the Phalahirda or Phalasarpik. It has the progesteronic influence means it is definitely anti-estrogenic, right?
Sir, reference of Gugulu Panchphala Kochurn.
Yes, Gulgulu Panchapala Churna having some anti-cystic effect as well as anti-inflammatory effect. Punarnava Gulgulu is the best combination. The Gulgulu Pitta Krirak also contains Gulgulu. And several combinations are available as far as our system is concerned. So Gulgulu Panchapala is also one of the best drugs for, or drug of choice, one of the drugs of choice for endometriosis. Due to its anti-cystic action, then anti-inflammatory action, and also it prevents the activation of T or the lymphocytic activity.
Sir, I am asking about reference. Which drug you have? Which books have this preparation?
Yeah.
Whether it is from Charka, whether it is from Bhaprakash, Gugulu Panchphala Churn.
It is described in Gulma Prajarana, Gulma, Vidradi Gulma, all these Prajaranas, the Gulgulu Panchabala. Vadastonida Gulgulu Pitta is described. Then with progesterone-like action, estrogen-like action, androgen-like action, this is one of, it is graded by me around 10 or 20 years back. And I have expressed this idea in some national or international seminars. So we can correlate the so many hormones with or it can so many hormonal medicine. So wherever some special hormones are needed, where our drug can be substituted. It definitely gives the hormonal action. But one of the most advantage is our drugs have the particle size is large. So the penetrating effect is slow. It will not hamper anything. Less than 1,000 Dalton size particle enter quickly. They are Krishna and Ruta. More than 1,000 Dalton particle size is Snigdha, Guru, etc.
थैंक यू सर। और किसी को अभी
Okay.
कुछ अगर कोई डाउट है तो, जैसे सर ने बहुत बहुत अच्छे से बता दिया है, एवरीथिंग ही हैज कवर्ड। इट वाज रियली ग्रेट लेक्चर, अप्रिशिएट।
Always thankful to you and the whole crew of Jamnagar.
Yeah.
Okay. Now you are shifted from Gujarat to Delhi.
Yeah, shifted to
Yes,
Delhi, all India Institute 5 with.
yes. Okay. I am very much interested in your eminent personalities. We are all under Ayurveda family.